Each year, Microsoft Research hosts hundreds of influential speakers from around the world, including leading scientists, renowned experts in technology, book authors, and leading academics, and makes videos of these lectures freely available.
So we're thrilled to have A.B. Flaxman here from the University of Washington Medical School, which is amazing to me because he was one of our postdocs. And he really shifted what he was doing. So you were our postdoc a couple of years ago, for 2 years, right? And then when he left us, he went to this new Institute for Health Metrics and Evaluation. And he's using his mathematics to do something good for the world, which is wonderful. And you're just around today, right?
Yeah, I'm just here for today.
But he has a little bit of time after the talk, so if somebody would like to talk with him. And you said that you're going to aim this at quite a general audience, right? Okay.
Yeah, no surgical technique, none of that.
I'm in here for it. See you dissect a frog.
We have also a very interdisciplinary crowd at the Institute of Health Metrics and Evaluation, and there is sometimes the risk that we'll have a weekly speaker come tell us about a new surgical technique. But for you all, it's really on the computational side of things. I, just like Jennifer said, come from a theory group postdoc, one of the last batch before Jennifer and Christian came out here to found Microsoft Research New England. And I had a great time there, but I started working with real data because that was available at Microsoft, and I had never done it when I was in grad school. And I found that I really liked it. So after I did my postdoc there, I switched to this postdoc at IHME, where I was continuing to work with real data and work with especially health data, which is real data that is really important. So,
as opposed to some other real data around here.
It's been really fun, and I hope in this talk to tell people who were like I was a few years ago about the really fun problems that have a computational side of things. And because this is a diverse group, I think there's also a lot of people from more of the social sciences side of things who can keep me honest and also maybe see how this business looks to someone coming from the computer science side of things. So I'll tell you about medicine as a social science, which is a quote going back to this kind of founder in public health epidemiology, Virchow, who said that 150 years ago. And I'll tell you how it's not just a social science, but now it's really a computational social science. And I'll do that through this particular lens of health metrics, which is the kind of medicine that I've learned something about in the 2 years I've been a postdoc. And this keeps showing not that was supposed to be a surprise that I was going to circle that, because I had it's skipping my punchlines. So this is really the only economics in this talk, which the doctors, I work with a bunch of sort of MD PhD types, and their PhDs are in economics, so they have this kind of macroeconomics / health perspective on things. This is the kind of thing that they spend a really long time doing, which is figuring out how much money different organizations are spending on health in different settings. And so they call it development assistance for health. It's money that's given dispersed by year. And what you can see, like many economic graphs over this time period, is that it's really gone up. Now, I don't have the next years, but unlike many economics graphs, this is expected to at least not go down. That there's really been a lot of massive scale up in spending on health, and it is going to at least persist at those levels for a little while, we think. And this is global, yeah. So this is looking at all these different categories on the right-hand side, and it shows you that there's about $25 billion a year being sent from different organizations around spending on health.
So is it because they actually provide better healthcare, or is it because more people are sick?
It's really development assistance. So it's because the countries or the NGOs or the international organizations on this list are interested in improving health, or because of all the other reasons that people have development assistance.
So what's U.S. in this list?
This is a very U.S.-focused list because of how the NGO money numbers come from, because they're mostly from U.S. tax returns. One thing I was going to pull out on this list.
More than that, right?
It might be more than this. It's definitely this much. Relevant to computation is the one foundation NGO that made it into its own bullet on this list. But I'll also tell you as we go on many of the other ways that this sort of health is relevant, computation is relevant to this sort of health stuff. They're all big sources of money. NGOs is kind of the broad term for that. The ones at the bottom are countries, so bilateral development agencies would be like the US giving money to a specific country. Then the ones in the middle are more like coalitions. And I encourage you to keep asking questions throughout the talk, but I'm not going to let you ask too many more about that one because that's all I wanted to do on it. Instead, I'm going to dive into the particular project that I've been most involved in, which is kind of my way of organizing the different challenges that I've learned about. It's called the Global Burden of Disease, or just GBD for short. And it's this massive undertaking to kind of gather all the world's data on 200 plus different diseases, injuries, and risk factors, and produce comparable estimates of the burden of these diseases. So if you're with me on this, I think there are kind of two responses, which is first of all, either like, that sounds like a huge amount of work, and how are you going to do it? Or else, if you're from the quantitative side of things, you just say, what comparable? What units? You know, what does that mean? How are you going to measure that thing? So the units of choice where I work are called the DALYs, Disability Adjusted Life Years, and they measure the burden of disease in two parts. Years of life lost, YLLs, so that's kind of the years that are lost because people died before their time, and years lived with disability, YLDs, which is sort of for diseases that injure people or that have,
And how do you get, for
disabling sequela.
different diseases, the relative scale factors from that to, okay.
Well, first of all, let me start by saying just the YLLs is a hard thing to figure out, how much life is lost. But that one's maybe easier to get your mind around. The YLDs, well, to figure that out, you need to know the incidence of the disease, so how much of it is starting. You need to know how long it's going to last. And then you need this conversion factor, a disability weight, which is a number between 0 and 1, where 0 says you're in full health, 1 says death, and for the sequela of the disease, where do you put it on that continuum? I'll tell you more about the strategies past and present for that later in the talk.
Wouldn't that be also affected by the treatment? So if I have diabetes, for example, and it's untreated, it has a huge effect on, so then I'd get a number, close to being dead. And if I have diabetes and it's being treated well, then I'd have a number close to being without a disability.
Absolutely. And so disability weights really has to do with the sequela or the conditions caused by the disease, not the absence or presence of the disease itself. So here's the kind of numbers that come out of it.
Do you measure, I can sort of, two very different measures. One is sort of how much money does society lose by the fact that I can only work with one hand or 3 fingers? And the other is how happy I am and how happy I'm not. So,
a health economist was telling me early on about their decision regarding this money stuff. They said, economists learned many years ago not to give dollar values to human life in this business. It really distracts people from the main point of your research. So we're going to avoid dollars strenuously. We're not going to measure happiness because that sounds too squishy. We're just going for years. And so
How disabled you are in terms of like what percentage of life function you can perform?
And the idea is there's some way to convert that into years.
So this is a uniform year. A person at age 70 whose arthritic would be different from a person at age 15?
You caught on to a very controversial point in the DALI. Some people like to discount years, but I think that the general headline result values years equally. Now, when you look at years of life lost, someone who's age 60, it's assumed that they will live to a certain age based on what's expected in the world, and that's less remaining years than someone at age 15. So it values their years equally, not their, yeah. So here's the kinds of things that you get out of it. This is for the United States. It was produced about 15 years ago. And it gives you these kind of comparative quantitative numbers that I was talking about, where ischemic heart disease is the #1 disease burden in the United States, and it's about 11% of our DALIs. And things that make it onto this list because of the comparative nature are things like depression here at number 10, which is not as bad as heart disease, but it doesn't kill really anyone, and it's still up there because people suffer from it for a long time.
Read through one of those rows and sort of translate that?
Yeah, sure. Let's do road traffic injuries, number 2. And so it says that the DALIs, the disability adjusted life years, are 934,000 for 1996 in the United States.
So it means that amount of years are lost in total that year by
Among males?
Good, thank you. That's for males only, and there's a separate table that I didn't paste in here for females.
Okay, and so then some of it is really just you die, and some of it is you're disabled, and those are those other columns, yes?
And that
death percent? So it's the sum of YLD and YLL, but what is death percent?
well, deaths is moving away from the DALI for people who like this simpler, just how many deaths were caused by this condition.
What is your weight factor the same for all of? I mean, so for example, for car accidents, the weight factor seems to, well, it's hard to tell for me because I don't know what your weight factor in the YLL is.
Well, I could jump straight to the weight factor for you, but I think I'll make you wait for it.
wait, so I want to
This slide is in just because sometimes people who haven't been thinking about death and disease a lot are upset by the beginning part of this talk.
Makes them feel good.
But, yeah.
the percentage at the end, that's from all the total number of deaths, 2.something% are from car accidents.
Yes. Yes.
So, just
You want me to go back?
in the second line, so the lung cancers, they just tend to kill very fast, so that's why you have a very low YLD, but overall.
Right. Right. So lung cancer is a big problem, and it's mostly YLLs that it's causing.
Good asthma makes sense.
Sounds more sanitized accent, YLLs.
Yeah. No, there's a lot of stuff like that, and that's because you don't have time to look at these pictures of puppies all day. So I'm going to focus on 4 different computational aspects in this business that I loosely have organized around coming up with those numbers. And this is my bullet list of them. I'll tell you what each one means as we go through it. They're the verbal autopsy garbage codes, disability weights, and something that I'm calling integrated systems modeling.
And different people gave these names, right? These names don't sound like they were, like the same person came up with.
Not a single one did I come up with. I'm stuck with them all. and everyone could be improved. But let me begin with the verbal autopsy, which is about YLLs, and it's about what are people dying of. Well, in the parts of the world that are not colored in on this map, you could figure out what people are dying of by looking at death certificates. The non-colored regions have vital registration systems that record pretty uniformly although I'll come back to this in the next bullet, what people are dying of when they die. In the beige, pink, and red regions in this graph, there's not vital registration systems. So you can see in almost all of Africa, if you want to know what people are dying of, you can't find out from their death certificates.
And how about the years? What is?
Well, so this pink, or this sort of beige that you can see in some of Central Europe or Central Asia, is places where there was a vital registration system. So if we go back to the 90s, we can get some data, but
I see.
there's not really current data available.
I see.
Why did
Well, because the countries fell apart. I mean,
Mongolia?
Yeah, Mongolia, for example,
the countries fell apart
had one,
politically or
but doesn't have a current
whatever.
one.
So how come that these northern countries don't have death certificates?
Oh,
You don't
Greenland?
have certificates
Because
for
there's no
the
people
holidays in Greenland.
there. Yeah, so there's a few quirks that I thought about cutting out on this map, but I ended up just leaving it. Those aren't, the big deals are the really populous countries in Africa, like Democratic Republic of Congo and Nigeria, where there's millions and millions of people, and your guess is as good, almost as good as the experts of what's going on there. So what are we going to do about it? Well, the big proposal on the table now is called the verbal autopsy. And this is a sort of retrospective study where you can send out an interviewer who's been carefully trained to be respectful to the household of the recently deceased to say, so I'd like to ask you a few questions. And they have these forms that they've come up with that have sort of yes-no questions, categorical and continuous data where they say, did Name have a fever during her last illness? And they mark this all down. They have a bunch of different types of data. So here's one where they just say, tell me the signs and symptoms that you observed in the order that they happened, and how long was that, and how long was that. Or they just have this free response area where they say, just tell me what happened. And they come up with thousands and thousands of these. And, well, what they do with them is they hire some physicians who have to be knowledgeable about the region where they've collected this data to go through the forms and one by one come up with the cause of death. And this is a great area for machine learning, for computers to replace these physicians, because these are areas with limited resources to begin with. The few doctors who are there should be freed up to help the people who are sick and not poring over the details of the interviews of people who've already died. So if you're into machine learning, I think that this really fits into kind of the questions of the day. We've got labeled data, we've got mostly unlabeled data. We can label data for a price, so it's even in this semi-supervised or active learning framework. There's a lot of expert knowledge about what is kind of believable based on age. There's an idea that there's relationships between these different causes, so we might know something about the hierarchies of these signs and symptoms.
How about getting one of these what's going on games to play on them? You know, like the expert doctor, if you and I match...
So how many expert doctors do you get to play against
teach them a little bit.
Well, I've been talking to someone a little bit about that, and it's not the doctors, I think, that would be the perfect target for it, but the wannabe doctors, med students, people who are preparing for med school. Yeah.
So is this a matter of the current data collection scheme, or just that we have so much data from the past? In the sense that there's been a large recent effort on doing data collection using mobile phone systems and so on.
Good question. So the sort of historical state of this is there was a lot of energy in the 90s coming up with the instrument, the actual survey form that experts really pored over and agreed that this is something that is doable but contains a lot of useful information. And it's been run in various select sites for a while now. So there's a lot of back data that would be nice to really know what's going on with. And then there's also really the possibility that it's scaling up in the future. So there's a lot of effort to kind of do the next step. As far as how it's collected, I I think it's in transition now. So there's probably still a lot that's collected written, and there's probably more and more that's being collected directly in an electronic format. So here's a cartoon of what's going on when you have these unlabeled data sets, and I'll just skip over that. This is my cartoon clustering, but what's exciting, and I hope to release to people who are interested in doing this within, say, the next year, is some really accurate labeled data that we've been collecting, where they've done a prospective study. People come to the hospital, they meet very clear standards for the criteria, so we're sure that they have a severe case of malaria, and if they die, then we think that's what they will have died of. And then we go back 6 months later and do an interview. So we have labeled data that has high quality labels. And once we finish working with it, then I hope we'll be able to make it available for other people to do their favorite machine learning and say, what can you do with this?
So in this case, at least, I mean, your final goal is to collect statistics on various things. So if you get a few things wrong, this is completely okay, right? I mean,
very interesting question. So, and I'll repeat it because I love this challenge, which is from the public health standpoint, we want to know the cause fractions. What are people dying from by and large? But from like a policy standpoint, from getting people to spend money implementing this, I think they really want to say to individuals, here's what we think your loved one died of, or here are the 3 things that we think. So it has, if you like, dual criteria in the objective, depending on whether you're trying to make kind of policy level decisions based on the data or get it implemented. And incidentally, now that we have this gold standard data, we can see how we're doing, both on the kind of macro cause fraction level and also on the individual level prediction.
What are the nodes? What are the edges?
Well, if you actually want to make that sort of sketch of a picture into a real algorithm, each node is someone who's died, and the edges are really the hard part, the secret sauce, which is coming up with some distance metric so that you can take a survey and convert it to a point, which is, if you can do that well, then you can cluster it, and if you can't do it well, then that's what you have to figure out how to do. And incidentally, the off-the-shelf algorithms, even if you tune them really well, get about 30% accuracy on these, which is 30 to 40% about what the physicians do as well. So it's one challenge is the straight-ahead machine learning, predict it well. The other challenge is kind of come up with some way to say how well you can do, because we've tried really hard, and I think that, you know, maybe we should just focus our efforts on some argument that you can't go beyond 50% predictive validity.
So what did you get?
We can get 40%.
What do you mean by 40%?
What is?
That you say what the disease, what the correct is 40%?
And now, to be very specific, there's about 55 causes of death that are in this data set. And so you're supposed to say, looking at one person's survey interview response, what did they die of from these 55?
Can it be a combination, or can it not?
In the health world, which will come into this garbage codes thing, doctors have agreed that one death has one cause. Part of the problem, but they really want to do single cause of each death.
Also, I have one other question. Like, if you look at the Philippines and India and some region, can you take data from one to the other, or are there such significant differences in the way people describe disease that you really can't do that?
There's a student who I've been working with who just submitted a master's thesis on that. It's still a point of a lot of discussion, but it seems like for most things you can take data from one place to another. And there's some things that you really can't, which some are nice, make sense after you see it, like suicide.
Yeah.
I just want to get a lower bound on what we should expect. So if you had a trained expert to try to predict of these 55 causes, what accuracy can we get?
The position coding also gets 30 to 40% accuracy. And most of the time when people have tried to assess this, they've given it to one doctor and given it to another doctor and said they agree on 95% of the data. So they're getting it wrong the same way over and over again.
So what does it mean that they're getting it wrong? How do you
Because we have this wonderful labeled data. So now we can give it to a physician without telling them what the gold standard was.
They actually diagnose the person before the person dies. Like they say, this person has malaria, now we send them home, and then they go and they interview their relative later, right?
So the interview doesn't have the information that the
Right.
physician.
So that's one thing you have to watch out for. Yeah.
And do you know like how good the gold standard data is? Like how long before they died was the diagnosis?
It's supposed to be really good, and so yeah, I think that one thing that we'll be able to see once all of these are scored is compared to the other. There's been 2 previous efforts to collect gold standard data which haven't been as careful, so we'll be able to at least see whether it's kind of.
Have you tried
More
this in the
or
U.S. where you actually look at what you would predict on the basis of emergency room visits and things like that versus what the death certificate
Yeah, that's what I
actually
remember.
says?
We're not doing it in the U.S. because I think people believe that sort of the deaths will be just too different, but we're doing it in Mexico, which will be somewhere where there's pretty good health system, and then we'll have a good idea of what's going on.
Wouldn't you worry about things like, I sent you home and I know you have really bad malaria? And then if your relatives claim you committed suicide, that may actually be more believable than your hospital data from 2 days ago.
This is ongoing research. So I'm going to shift now to the more.
When doctors do the review, do they specify how much certain they are about their diagnostics?
No, they're always sure. The doctors, this is what you'll learn. They're sure. So
They have to specify only one diagnosis, right? Like they can't say that like 50% is 50%.
and where they have a functioning health system, thank you for the segue, they really fill out a form that looks like this. It says the cause of death, the direct cause of death goes in line A, and that was caused by B, and could go all the way down to the single underlying cause of death. Then if there's other things going on, they can put those in box 2, but those are not the cause. That's just other interesting things. So here would be an example of a really nicely filled out full form like this for someone who had breast cancer, which is line D there. But the direct death was caused by pulmonary embolism. That was caused by a bone fracture. That was caused by bone cancer, which was metastasized from the breast cancer.
Approximately how many of these do you have in electronic form?
Oh, we've got many of these.
Hundreds of thousands, millions?
Millions, yeah. Where there's a paper called What and Where Are a Million People Dying, or something like that. That's the first one that broke the million mark for these.
So
But they don't have like full microdata for the million, so it's partially summaries and partially individual records.
you train your system based on the actual diagnosis before, or how do you?
Well, in this one, you can just read off whatever the last line in that top box is, unless it's obviously wrong. And here's an example of one where you can't read off the last line in the top box because it couldn't have caused the second to top line because the second to top line was a condition for 14 years and the last line was a condition for 24 hours. Now, it's a clear typo, right, because this hypothyroidism should be in box 2 as a related condition. But if you just make a list of the kinds of
Maybe
things...
it was 24 years instead of 24 hours, right? That's another possibility.
And I don't want to say how to fix it. I just want to say we'll make a list of things that are obviously wrong and look at how many of these death certificates are obviously wrong by country. And you can see that it has a lot of variation. New Zealand is kind of the best country in at least not making obvious mistakes in their death certificates. They have about 10%. And Thailand is really, at least at this time, was one of the worst, where they had about 50% of their death certificates just obviously not correct. So this is computational challenge number 2, and global burden of disease. That's the study that's been synthesizing all of this data. And so the different colors in this are kind of the different iterations of those rules of what's obviously wrong.
Realized it was wrong. They first passed through and said, okay, well, these diseases are not even well defined, and then they did a study of those 12 years, and they added some more, and then they did a study and they added some more.
Yeah, so as far as the colors, that just makes us look pretty. Just ignore those.
And is there any conceivable reason that, people in Thailand may just be following a different protocol and it's not consistent with the questions you're asking?
There's plenty of room for theorizing about this, and it's partially, I think, about the amount of resources that are being devoted to this system and the sort of incentives that are in place. Do people care about the data? Do they make it clear they care about the data?
Oh, actually, I can understand what it's saying.
But that's the challenge, is to understand what it's saying. So
it's not like it's coming from stigma of certain diseases, and so they
certainly
intentionally
is. It certainly is
misdiagnose.
sometimes coming from that.
Yes.
And it's certainly coming from certain cultural things where they just say that this is a died of old age.
Right. Nobody dies of venereal disease. Nobody, whatever, yeah.
But so even in the United States and Canada, there's about 2 million obviously wrong records in 2002. And so what they do now is proportional redistribution. They say, okay, take away all the things that are obviously wrong, calculate whatever you want from what's left, and then just add those back in so that you've said that if there were 15% of heart attack deaths.
I mean, AIDS is going to be, AIDS, suicide, venereal disease are going to be systematically underreported, right?
And when I was thinking about this is the place for the computational lens, the algorithmic lens that we've been talking about. Because through the algorithmic lens, doctors are noise machines. So here's the schematic. They look at this truth about the world, and they have this little algorithm for screwing it up before they write it down on these death certificates. So I won't go through this. This is just a schematic of what it might look like. But and then try not to burn them with my algorithmic lens.
So now a dog and a cat.
Soon.
And you're trying to get tenure in a medical school.
Right, doctors
Half of the
have-
time they study how to write, so no one
I mean, there's also the fact that doctors don't want to do this coding. This is really like a chore that doctors would prefer to avoid. And so
How often is actually in this death certificate something where sort of the police actually has to look at it?
Doctors are still supposed to.
coroners might do it. So you can definitely imagine, in a suicide case, I've heard anecdotes that nothing will be coded as a suicide unless there's a note, that this is maybe a coroner who maybe goes to church with the family, maybe is, that there's just a lot of stigma for certain causes. And so that, I think, is a great area, and I think I'm just on schedule. So keep the questions going. It's going really well. Now we will turn to that conversion factor that got so much interest in the beginning, which is the disability weight. So recall, DALYs have two parts. The disability life years made up of the years of life lost and the years lived with disability. The years lived with disability has three parts, the way we're doing it: the incidence, how many people are getting it, and the duration, how long they have it, and the disability weight, which says, on a scale of 0 to 1, how bad is it? And that's exactly how they did it in the first iteration of the global burden of disease.
Now, wait a second. So do you use means of the distribution, or what do you do when you have, if the distributions are not tight, what do you, because...
You convene a panel of doctors.
I see.
And you say, for a face rash, what would that be? And you want to make it simple, so you say, imagine this ruler. Where point to the point on the ruler, and then they discuss for a few hours and come to a consensus.
But there's a distribution, so are you just asking this panel of doctors for a mean?
Oh, well, it will be for a specific, not for duration and not for incidence, just for the weight. Yeah. And it will be very specific sequela, so it'll say, in maybe more basic terms, the severity of this. And so they will always tell you things with great confidence, so they'll tell you it's a 0.3 for deafness. And for active psychosis, it's about a 0.9.
What do they mean? So what does it mean that my ear sounds sort of that I lost half a year?
You have to be very specific about what you're going to use this information for to really understand what it means to convert between these things. And so what we're really using it for is sort of priorities in research and in interventions, and we want to know questions about policy. Now, when they first started doing this, they came up with these really terrible ideas, like, well, just ask people about what you mean. If you could choose to save the life of 100 healthy people or 200 people who were deaf. But this makes people very unhappy. So we're running a study now that we are attempting to address this with. And we're using the same approach, really, that's used in Kitten Wars, which in Kitten Wars, they want to find the cutest of the cute cats, and they give you two and say which one is cuter. In our new disability weight survey, we give you two conditions and say,
have like your arm cut off, or your leg cut off.
and it's important to look at what we're going to use it for. So it's not you. It's actually phrased as who is healthier overall. Imagine two people, each with an equal amount of time to live, one with condition A and one with condition B. Who is healthier overall, first person or second person?
With the quantity or without?
We're asking everyone. In fact, you're invited. So go to gbdsurvey.org.
You're not going to Mechanical Turk or something. You're just.
Wait, why do you say healthier? Why don't you say happier?
That's not what
this is just about health, right? And doctors are good with definitions. So they're really just looking at the domains of health, which is very expansive, but we don't have to worry about, if they have satisfaction in the workplace.
This is great for getting in linear order, but what about the scale?
Right.
Yeah, exactly.
No, but even, it's not going to be a directed acyclic graph, right?
Both valid questions, and because I'm doing a broad survey, I won't tell you how we're going to address that, let alone what the right way to address it would be. But this is very clear domain for computational research. It's the kind of questions that go into sorting. And we don't need to just sort things. We need to come up with exactly the metric embedding, if you like, the numbers.
So why do you prefer just random people's answers rather than doctors?
Right.
Well, there was a lot of criticism for just looking at doctors. So it'll be interesting to see if people now turn around and say, how can you ask these masses? You have to know experts.
No, but I mean, think about doctors. Doctors, when you talk to them, since they have to deal with death or disability in a particular domain, they become kind of, totally insensitive to disability in the domain that they're normally dealing with, or they wouldn't be able to function. So they probably are going to.
The best outcome will be
Of certain disabilities, whereas if you just think about I don't have a finger yet, it's not a big deal, but you don't realize that you cannot write, then
Well, the great thing will be if we can gather this data from a really diverse collection of participants and then find that things are pretty common, I picked this one because I thought it was actually pretty hard, but in the things that we're trying to order, some of them will be doable.
So how are you, who are the people? Anybody can go online and
This component of the survey is online and it's open, and anyone can do it. And it takes some demographic information so that we can say what country you're in, what age are you, what income level.
They're very reliable.
But it's not it's not a...
Also, from a statistical point of view, if you're getting people to log on, you're getting a very skewed sample of
specific
people.
sample, and we're hoping to get a lot of people. So we're aiming for 50,000 responses to this.
But still, the kind of people who would go
No, it's absolutely right. And this is
They're probably
complemented
people who
with...
have disabilities.
This is This is only part of the study. So they're also going to households that are sampled with, statistical sampling techniques in 4 different countries and 4 different regions of the world.
First, second person, because you could also ask someone, would you rather be somebody who has A or B?
No one would fill it out.
And that's probably a little bit different.
That's bad with this, but would even be worse if you asked what Crystal suggested, which is getting the public to separate condition from prognosis.
Yes.
You can say which is worse, say, incipient prostate cancer or a limp, right? Well, which one affects your life more is by far the limp. But if you ask people what they prefer to have, okay, well, maybe they'd rather take the limp. But for this purpose, you don't care about prognosis, you only care about current condition.
And it's really, they went to great lengths to write it in simple terms about the condition. So the kind of what's going on in the long term is supposed to be minimized, but it's hard.
Don't people multiply it in their head by the life expectancy of having it?
Well, they're not supposed to. It says imagine the same amount of life for each.
Where does it say that?
In the introduction.
Does this tend to come up with a different ordering than the doctors do?
We don't know yet. Yeah, that'll be really interesting to see. I think that the kind of preliminary results are to say it's pretty similar. So, I'll tell you about one more piece of this business, and this is actually the one that I've been involved with the most. And I've inherited a name for it, which is a little bit strange, so if you come up with a better one, I'm open to it. But for today at least, I'm calling it integrated systems modeling. And so this is the sort of disease modeling that I kind of heard about and imagined when I wasn't looking at health stuff, but was just in math, but very much combined with data. So in the global burden of disease, we've touched on everything that I put in that DALI breakdown except for the incidence and duration of the disease. And what I'm going to tell you about in a pretty broad stroke for part of this integrated systems modeling business is the way we come up with the incidence and duration of these diseases. And what we do is we kind of cull the literature, come up through a systematic review with all of the studies and all of the things that they've said, and then put them together through a pretty simple model of how disease goes through a population to come up with consistent parameters for the way incidence, prevalence, remission, fatality are related. So you can put it in a little compartmental model, just a flow chart, that says, in this case, there's people who are healthy or susceptible to the disease, and they become diseased with some incidence rate and recover from the disease with some remission rate, all the while with a background mortality that's killing them through all other causes and an additional case fatality rate that they're exposed to if they have the condition we're talking about.
Yeah. They never get immune?
And in this generic model, they don't ever get immune. And once you give this to the disease experts to fit their data in, they all come up with additional compartments they want in their model. But for now, I make them just take these 4. Maybe next time around, they can add their own compartments. So if you like, this can be just a system of differential equations. And what's surprising is that what people don't do very much with these systems of differential equations is fit them to the data, which is really what we're trying to do. And I shouldn't have put this slide in. This is way too much statistics. But basically, we just put on a simple statistical model that says if you've got, say, a prevalence study, then what's the probability of seeing that given the parameters that were in that differential equation on the last slide. So how do you do it? Well, it's my old friend, MCMC. We just put it all together and then run it for a long, long time.
Friend, so you should at least say what it stands for.
And use
MCMC stands for
Markov chain Monte Carlo to come up with samples from the parameter space. And this is the kind of thing that I was doing full-time when I was a graduate student. I had a wonderful time doing it, but I never really did anything that I thought was useful at all with it. I was always sampling things like random colorings of random graphs that was very fun, but not clearly applicable. But what I learned a lot about, well, it was clearly applicable to putting pages in my thesis. But it's extremely relevant to this business because the kinds of stuff that I'm faced with when I come up with one of these models is, how do I get the parameters from, this strange probability distribution I've defined? And the answer that I love, although I have colleagues who say this is no good, is you just take a random walk in a appropriately defined probability space, and if you've done it right, you end up with a nicely distributed picture, sort of symbolized by the one on the left. And if you've not done it right, you end up with this mixing, bad mixing time, this random walk that's kind of stuck in not mixed like this one on the right. And one of the great there's tons of great computational challenges in this. So how do you walk around in this space? How do you define it? How do you know that you've mixed is kind of the big one. And a lot of the way it's been approached, I think, in the theoretical computer science approach is to say for very specific random walks, we can see that it's mixed. But every time I come up with the model and have it set up, my doctors want to change it a little bit. So I can't really spend the weeks or months that it takes to prove that a particular model is rapidly mixing, which might be really hard anyway, because even if I succeed, they're going to change it. So one computational challenge that I've extracted from this is some kind of evidence of mixing, which is totally justifiable because they're coming from this Bayesian framework where they're just looking for weak evidence that the parameters are right in the first place.
So from the model, you're trying to see whether it fits your data in terms of incidence and duration and so on.
And I'll show you another one that has better pictures of how the data and the parameters come together, because I sent in this talk on Friday and then I felt like they might be upset if I changed the slides on it, so this doesn't have quite enough pictures. But I just wanted to say that when I was starting this randomly sampling from convex bodies business, Glasilovas once asked, do you think people really care about sampling from convex bodies in high-dimensional space? This is a picture of a room full of people who care about, well, not how to sample from them, but the results that come out. And they care about, like, this picture, which put together this totally crap data that you could pick any value and then come up with a study that supports it and says for this Guillain-Barré syndrome, which is a cause of paralysis, that the age pattern has this particular age pattern that experts find, plausible based on their experience. It's kind of increasing, although it levels out when it gets to oldest age.
I mean, the Guillain-Barré syndrome is like a super rare syndrome.
Yeah,
so
that's
true.
Kind
of cheating. It's like 400 people.
No, it's not that rare. But yeah, it's the incidence rate you can see has 4 zeros before it. But we're doing this with 199 plus other conditions. So this just happens to be one that they did early that I had handy when I was making these slides. And I'll show you another one really quick. This isn't from the global burden of disease, but it's one that uses the same framework and I think is nice because it makes them seem like a general approach. So in the short story, malaria, bad thing, insecticide-treated mosquito nets, one of the interventions people are really excited about for it. A huge amount of money has been poured into it, but people are not really sure how many nets are making it to households. There's 3 different sources of data for looking into this, and I'm going to do the same thing where I come up with a compartmental model and fit it to the data, and the goal is we want to say how much household ownership coverage is there. That's, for example, in this picture of Uganda. In 2000, there was very low ownership, and in 2006, it had gone up some amount. And so we've got these 2 points. Just fill in the rest of the curve, and if you don't mind, project it forward to the present day, or maybe a couple years in the future. So all right, we'll try. You got to try.
Typical questions like if there's model misspecification or hidden variables that may not.
Well, you have to look at it some, but yeah, I think that one of the arts of this is coming up with a model that's appropriate to the data that's available, but doesn't go too far. And I'll show you the kind of model that I'm looking at, which is really not putting huge assumptions into what's going on. It says sort of for a net to end up in a household, it first has to be distributed. And to be distributed, it first has to be manufactured. And so there's this pretty fundamental model of how supply chain distribution works. And then there's somewhat questionable data, but data available for the different links and compartments along the supply chain. And so...
Why are you discarding data for 0 to 2-year-old nets?
So that's not discarding the data, but that's actually a model for how nets go through the system. That is, they end up in a household, and some portion of them get discarded during their first year in the household. And I actually model this as saying there's just a constant risk. So some proportion of the ones that make it through the first year.
Process or something.
Precisely. But these are long-lasting insecticide-treated nets, which means after 3 years they're no longer insecticide-treated. That's kind of the model anyway that people believe, although there's not a lot of data on it as of yet, to say that after 3 years it's no longer insecticide-treated.
Can you wash them?
Yes, and people wash them. And this is a big question in the insecticide treatment is, does it stay on? So hopefully there will be more data coming in soon that we can add to this to make it more accurate.
I have a stupid question. If it's a net, then why do you need insecticide?
Well, that's so... 20 years ago, people were very excited about nets. Just put the nets out there, and it'll prevent people from getting malaria. But it didn't fight malaria as much as people were hoping. So 10 years ago...
How do they know that it wasn't just that the nets weren't being used?
Well, one thing about the insecticide treatment is that it fights malaria even if it's not being used. As long as it makes it out of the bag, it's there for mosquitoes to land on it. And if it's over, say, a sleeping child, now this child is sort of mosquito bait, luring in the mosquitoes to the net where they then are exposed to the insecticide.
So the no, the child is the bait.
Right. And the insecticide makes these net interventions have indirect benefits as well as direct benefits.
I see.
But there's a lot of questions still to be seen about how long does it work, does the insecticide last, how often are the nets being used, and are they being used in a way that was intended?
So in this kind of a model, what you're trying to estimate is these 4 parameters or something, and what you...
This is what I want to do, which is take the data that I showed you 2 slides ago, and then sort of fill in lines like this that say the scale-up was actually pretty rapid. And there's good data to support that because when they did the survey in 2006, we had this microdata where they said, okay, and when did you get that net after they saw it? So that's pretty believable, saying that the scale-up was mostly close to when the survey happened.
So why did you fit 2 points with a curve?
Because they have this wonderful model. And regarding the misspecification, so the way this model works is it borrows strength from other countries, which have said if you see this kind of manufacturing and this kind of, these blue dots come from country reports, administrative data, then the 2007 through 9 distribution numbers will look like this based on past experience. Now that's something that's very sensitive to the model specification. And so this projecting forward, you may have heard that prediction is very difficult, especially about the future. So it's very sensitive to how you're borrowing strength between regions. And they should really do more surveys if they want to know what's going on when they're doing massive distribution. But in the absence of the surveys, you got to try.
So is one of the things that comes out of this that you should take more of the money and spend it on validation or surveys or whatever and less on the, I don't know.
I think that people in my business always say you should spend more money on validation, so it comes off as a little bit of a conflict of interest. But yeah, yeah, if you want to know how things go, this is really important, monitoring and evaluation.
And we were wondering what your view, maybe we should wait till the end, and you can just put this off to the end if you want, but what your view of Paul Farmer is, you know, Mountains Beyond Mountains, who basically says ignore all this science and just do the most you can for people. So anyway, I'd like...
I'll come back to that.
You'll come back to that, okay.
But this is the kind of thing that you can do when you've done this systematic synthesis of all the data. You can make a flip book where you see that there, first of all, really has been scale-up. If you look in 03, there's nothing in the target. The target, by the way, for this BedNet stuff is to have 80% coverage, and this is something that the World Health Assembly agreed to in 05, that they wanted everyone to have 80% coverage.
Why is South Africa doing so badly? Is it because they're not being...
The countries are all still red.
Right, that's really weird. Is it
One important point about this is that
they don't need it as much?
They don't need it, right. So this is a map that has a conservative estimate based on the populations at risk. So in South Africa and in a few of the northern countries, there's not full risk of malaria. So it's in this model saying that the nets are distributed pretty equally, but that means that a lot of them are going to people who didn't need them. And you can change that around to say, well, what if the nets are going to people who need them? Then actually South Africa still doesn't have very high coverage, but it's much less people who need it. And some of the other countries like Djibouti have very high coverage.
Is there some notion of design here where you say where to get a certain percentage of nets and the replications we could eliminate malaria?
Oh, well, people who are very interested in elimination are very nervous about promises that nets will lead to elimination. But yeah, I mean, that's the Gates Foundation's stated goal about 3 or 4 years ago, was to revive the effort to eradicate malaria. And this is a very interesting and controversial project. There was a big push to eradicate malaria in about half a century ago, which one of the lessons learned is like, don't pick a fight with malaria unless you're going to win. So, because if you get exposed to malaria when you're a kid, then you develop a immunity to it. And if you don't get exposed to it when you're a kid, then it's more severe if you get exposed to it later.
What's that country that remained yellow between 20 and 39 forever? I mean, that's Zambia.
Yeah.
So it just didn't work there for some reason?
It was an early program that had a fair amount of coverage.
But then it didn't.
And well, presumably we'll see big scale-ups in it now because that's been really a focus country in general development assistance for health. But yeah, the data they have now hasn't shown it.
Okay.
Sorry, was on topic, but
do any countries use DDT anymore?
Yeah, and what they call it is not DDT, but indoor residual spraying, IRS. And so the idea is the idea there, is that you can spray with whatever insecticide you think is appropriate, and you'll just use a limited amount just on the inside walls of dwellings, and then mosquitoes, after they've had a meal, land on the walls where they'll be exposed to the insecticide. But the insecticide that's used for spraying is, I think, largely DDT. And there's a lot of...
Had a meal, so that means after they've bitten me, they'll land on the walls.
Right. So it's...
The next resident of
Good
this
as
house.
that?
Seems like it's less protective than nets, and seems like it has more harmful side effects than nets. But it's out there as there's sort of 3 main interventions for malaria, and that's one of them. And the third is effective treatment. So there's a new class of drugs that they use to fight malaria that also prevents transmission.
DDT, I'm sure it's not something else. It's not DDT.
So to recap, I talked about 4 very diverse areas of global health, and I've really been having fun dabbling in all of them, and I hope I communicated some of that fun to you. And for more, there's plenty you can read, and one of the sources is this blog that I've been working on, Healthy Algorithms, where I've kind of tried to put some of these different problems into capsule format where they can make their way to my computer science colleagues who could also be having fun with them. So thanks.
So would you say that you've been having some success with the computational things? I mean, you described a bunch of problems, but there was no...
Well, I just started. Yeah.
So not necessarily you, but I mean, in general, the computational social science aspect of it, is it sort of, is it influencing the field? Is there hope?
Yes. There's really, I think, a big push towards using appropriate methods for these big data sets, big questions, and just, I mean, from what I've been seeing there, computer science skills are some of the most relevant skills to have working in global health.
How old is IHME?
It's 3 years. It's been at the University of Washington for 3 years.
So there's not much time yet, and presumably there haven't been that many things like this going on at other universities, or?
It's pretty new as a discipline.
No, I mean, this kind of approach. Obviously, people have been studying global health, but this kind of more quantitative, or?
Yeah, I mean, this is really, it's very influenced by quantitative political science. There's actually a crowd at Harvard that's done a lot of this stuff kind of in the political science domain. And
already sort of people taking in with data analyzed by these methods and trying to influence public policy, or it's likely to happen, or it's already happening?
Well, there was the biggest sort of success influencing at least the discussion of global health policy was from a paper that IHME people did about 3 or 4 months ago about maternal mortality rate. So they reanalyzed all of the world's data on maternal mortality and basically released a paper that totally changed the story of what's going on with the work to reduce maternal mortality. So there's a Millennium Development Goal to greatly reduce maternal mortality. And sort of the previous narrative had been, we're not making any progress on this and we need more money and resources. And the reanalysis said, actually, we are making progress on this. And now it became this political thing. Not only, have we made great progress, but we could actually, maybe, if we really push, make this goal if we have a lot more money and resources.
So regardless, you need more money.
So the policy recommendation didn't change, but I think that the framing changed in a really important way. And it's, I think it's true. It's sort of good science that's given us this. And it has secondary implications, like there's a debate about how to do this. What should you do with your money if you want to reduce maternal mortality in sub-Saharan Africa? And what this analysis says is that you should be looking at HIV, and you should be looking at getting people who have HIV on treatment. And that maybe makes more difference than having emergency surgical care, which is another big idea of what's the problem. But
A lot of the funding for IHME is from the Gates Foundation, right?
Yeah, the core grant was from the Gates Foundation. And
which makes sense, because Bill likes
Gates Foundation is very interested in metrics. And one of the first big studies by IHME was critical of a program that Gates Foundation was very fond of also. So it's been interesting, establish our independence early on, I guess.
Okay. Any other questions?
Are you willing to comment on the question Jennifer asked?
Oh yes, the Paul Farmer question.
I almost got away.
You almost got away, yes.
Go ahead, Ben,
why don't you ask it?
Oh, sure. It's just kind of what we were talking about in our conversation before, which is like the tension between kind of putting money in, like pursuing the goal of comparative effectiveness, kind of like full steam, versus kind of like trying to divert some resources to kind of like saying, wait, maybe we need to just be kind of giving medical care to people kind of immediately. And just kind of comment, I guess, on what you feel about that tension between us.
I think that the challenge for health metrics is to monitor what's going on, because I think you need to know what's going on. What should we be doing? How are the things we're doing working? What are we looking for in the future? But you have to do that without getting in the way of the actual work. So it's really an area that computer science is very applicable to.
Maybe you should use a multi-armed bandit for explore, exploit.
But yeah, we need to...
Like meta machine learning, you know?
We need to stay out of the way. I mean, if there's money that could be saving lives that's instead going to monitoring how we're not saving lives, then it's a failure. But we need to know what we're doing.
So I imagine that doctors' time is even possibly as much an issue as money, and therefore if you're using someone like you who has no capability to do it, that's all plus.
That's exactly what I told them.
Right, and that's why he's here to convert you. Okay. Awesome. Thanks, David.